Dear ladies and gentlemen, welcome to another webinar brought to you by the Malaysian Obstetric Medicine Society. A slight deviation from a purely maternal medicine topic, I think it is important we address the controversies related to progesterone, which I believe is extremely important, especially when it's often used to prevent miscarriages among patients with recurrent miscarriages and also to prevent preterm labor, which is an essential part of maternal fetal medicine. With that, ladies and gentlemen, I would like to declare that I've got no conflict of interest for this talk, but in the next 20 minutes, I'm going to dissect the evidence related to progesterones and its controversies. So why this lecture, ladies and gentlemen? I believe, firstly, there's the lack of evidence-based practice when it comes to progesterones in pregnancy, and it's often used in a controversial manner. I believe most of the current practice in obstetrics is because of an old study, unupdated study, but most importantly, it is influenced by pharmaceutical industries. Most medications are influenced, especially progesterones. The million-dollar question, should we still be giving progesterones orally? I shall answer that in the next few minutes. Question number 3, prophylactic use of progesterones among asymptomatic women to prevent miscarriage. What is the evidence? Should we or should we not? Should we give it prophylactically? Should we give it if the woman has got a past history of recurrent miscarriage? Or should we give it when it's symptomatic? I shall discuss that in the next few minutes. And finally, is there still a role for hydroxyprogesterone in modern obstetrics? What are the concerns? What are the recent evidence? And finally, moving forward, what type of progesterone, what route of progesterone, when and who to give, will be all be dissected in the next 20 minutes. Ladies and gentlemen, let's ask the theory behind the progesterones and why for many years obstetricians have loved the progesterones when it comes to pregnancy. People believe that progesterone aids in endometrial implantation and improves pregnancy outcomes. People believe that the progesterone, the name actually comes from the progestational theory that supports and improves pregnancy outcomes. People believe that giving high dose of progesterones reduces inflammation, and that plays a significant role through the immunological theory during pregnancy. People also believe, apart from preventing miscarriage, it also prevents preterm labor by causing myometrial relaxation. And that also people believe is why progesterone prevents preterm labor. Now, some important facts about progesterones. Progesterone is released by 3 essential sources during pregnancy. The corpus luteum in the initial stages of pregnancy. Then it is taken over by the placenta in the later stages, towards the end of the first trimester, at the peak of the second trimester. And these are not the only 2 sources of progesterones. It is also released by the adrenal glands. It has got a very short half-life of 5 minutes. It will act very fast. Now, the issue is progesterone, ladies and gentlemen. If you give it through the oral route, it undergoes the first pass metabolism. It is completely metabolized by the liver, and the absorption is low. So principle number 1 when it comes to progesterones, it cannot, should not, and does not work if it's given orally, because nearly all progesterones taken orally is metabolized by the liver and by the gut. And that I hope is an important take-home message from this lecture. So let's talk about the luteal-placental shift, ladies and gentlemen, an important concept to be appreciated by all obstetricians. Well, we know in the first trimester, the corpus luteum is the primary source of progesterones that sustains the pregnancy. Then comes the important shift known as the luteal-placental shift, which takes place as early as 6 weeks. But the function of the luteum comes down when the function of the placenta goes up. And as early as 16 weeks, the placenta entirely takes over the entire source of progesterone during pregnancy. So if one was to talk about progesterones, the first 8 weeks, the source is the corpus luteum. The placental starts to function after that and peaks at 16 weeks. And that is why people usually do not give progesterones beyond 16 weeks. Let's talk and address each and every single controversy, ladies and gentlemen. Controversy number 1. Can synthetic progesterones be given orally? The answer is no, because every single progesterone given orally will undergo a first-pass metabolism by the liver and by the gut. It does not work. Progesterone cannot be given orally. Controversy number 2. But before we talk about controversies number 2, let us appreciate the various types of progesterones. There are 2 types of progesterones: the natural progesterone, which can be given in the form of a passively or a gel, and the human-made semi-synthetic progesterones. The 2 types of semi-synthetic progesterones in the market: the IM hydroxyprogesterone, which is no longer in favor, and everyone's industry-favored, commonly abused progesterone, the oral dihydrogesterone. Now, the dihydrogesterone is not a natural progesterone. It is a semi-synthetic progesterone. So the type of progesterone which is preferred during pregnancy is the natural progesterones. Now, what is the progesterone controversy, you may ask? We appreciated that it cannot be given orally. We appreciated that all progesterones should be natural and not synthetic or semi-synthetic. But let's talk about the elephant in the room, the hydroxyprogesterones. So the IM hydroxyprogesterone was first approved in 1956, almost 70 years ago, with the aim to prevent preterm labor, to prevent miscarriage, especially if the patient is symptomatic. But fast forward almost 50 years ago, there were already concerns with regards to hydroxyprogesterone. There were already some red flags that hydroxyprogesterone is associated with fetal heart defects, and they were concerned. And because of this concern way back in 1973, FDA rightfully, quickly, and timely removed hydroxyprogesterone as an indication to be used during pregnancy. But the biggest controversy, ladies and gentlemen, came out in 2003. One single paper published in the New England Journal of Medicine showed, contrary to the past belief, overcoming the controversies about the risk of hydroxyprogesterone, that giving hydroxyprogesterone reduces preterm labor, and that changed practice. Because of this one paper in 2003, the world re-looked into the benefit of hydroxyprogesterone. It was quickly reapproved because people thought this medication is going to make an impact and going to make a change. And the FDA withdraw its concerns about hydroxyprogesterone. Fast forward after 2003, many people started using hydroxyprogesterones. The concerns in 1973 came back again, and now we know there are some fetal concerns. Once again, not new. We knew this 50 years ago, that hydroxyprogesterone is associated with fetal toxicity. The 2 studies that changed practice. The EPIC study, which showed, just in line with the 2003 New England Journal, that hydroxyprogesterone may be beneficial, but a prolonged study laid it to rest and showed hydroxyprogesterone does not prevent preterm labor. But let's take a look at the papers in detail. So, ladies and gentlemen, this one paper remained the most controversial paper of all time related to hydroxyprogesterone. It was published in the New England Journal of Medicine in 2003, which showed if you give women 17-alpha hydroxyprogesterone IM, you're going to prevent preterm labor. And the whole world changed, and the FDA withdrew its initial concerns with regards to hydroxyprogesterone. Then, 17 years later, the EPIC trial, which was a multi-centered randomized controlled trial that looked into various types of progesterones, be it vaginal progesterone or IM hydroxyprogesterone, and they showed that by giving patients progesterones, either type of progesterones, you're going to prevent preterm labor before 34 weeks, especially in patients with a shortened cervix. So the EPIC trial re-strengthened the fact that was known in 2003. But after that, ladies and gentlemen, every other study in the modern world in obstetrics showed hydroxyprogesterone was and is not beneficial to prevent preterm labor. So the biggest trial of this decade, the 2020 study called the Prolonged Study, which is the multi-center international randomized double-blind trial that looked into hydroxyprogesterone and whether it prevents preterm labor. The evidence was clear, ladies and gentlemen. If you give asymptomatic women, if you get women at risk hydroxyprogesterones, it does not prevent preterm labor. And those were the conclusions of the prolonged study. So when did we finally lay the hydroxyprogesterone to rest? We knew this in 1973. We knew this in 2020. It did not work. But this paper by Murphy in 2022 that showed a significant concern, especially among male fetuses, that if we give hydroxyprogesterone, it is not beneficial, but that is going to cause cancer among offsprings, especially if it's given in the first trimester, especially if it's a male fetus, especially if it's given more than 3 doses in the first trimester. And this paper, ladies and gentlemen, I believe laid the hydroxyprogesterone controversy to rest. You can Google this up online. So let's dissect hydroxyprogesterones further. Based on the current evidence in the modern world, there are no benefits in preventing miscarriage. There are no benefits in preventing preterm labor. But what are the concerns? There's the risk of childhood malignancies, especially among male fetuses, especially if it's given in the first and early in the second trimester, especially if one was to receive 3 doses. So what is the best practice moving forward, ladies and gentlemen? Based on this evidence, I think if one was to give hydroxyprogesterone, the decision should be discussed, disclosed, and should be a decision made weighing the benefit and the risk. And this information should be counseled to the patient before giving hydroxyprogesterones. Controversy number 2. We knew that the oral route should not be given. Is there a role for IM hydroxyprogesterones in modern obstetrics? My own take, I believe there's no role because number 1, there's no benefit. Number 2, there are concerns with childhood malignancies if it's given in the first trimester. So I, for one, believe that based on the current evidence, there's no role for IM hydroxyprogesterones in modern obstetrics with regards to miscarriage prevention and preterm labor prevention. Now let's talk about the other trials associated with miscarriage prevention. It was the 2015 PROMISE trial, just published in the New England Journal of Medicine. Now this trial was an important trial that buried the controversy related to progesterones to prevent miscarriages. Now, this trial randomized women who were given progesterones in the hope of preventing recurrent miscarriages. And based on the 2015 PROMISE trial, if you give all women who are asymptomatic, progesterones does not prevent a preterm labor, especially if the patient is asymptomatic. So we should not routinely prophylactically give progesterones in the hope of preventing a miscarriage. And there is evidence from the 2015 PROMISE trial. The same authors followed up with a 2019 PRISM trial. So the PROMISE trial were asymptomatic patients. The PRISM trial 4 years later looked into symptomatic patients. And similarly, it was of a randomized trial. And they randomized women who were symptomatic, who had bleeding in the first trimester, and whether progesterones helped or not. And once again, based on the 2019 PRISM trial, giving progesterones even among symptomatic patients did not actually reduce the incidence of miscarriage. However, ladies and gentlemen, the sub-analysis of the 2019 PRISM trial is interesting. Although across the board, it did not reduce early miscarriage, it was beneficial for a certain subset of patients. Based on the secondary analysis, if the patient has got a prior history of miscarriage, or the patient has got a history of recurrent miscarriages, and the patient is symptomatic, this cohort of patients, if you give them vaginal progesterones, there seems to be some benefit, there seems to be some improved outcomes, especially the patient is symptomatic, the patient had a past history of miscarriage, and that is the secondary analysis of the PRISM trial. So based on that, ladies and gentlemen, the 2019 paper was essential, especially the secondary analysis. And then came the most recent NICE guidelines, which now recommends progesterones if the patient is symptomatic and in patients who have got prior history of miscarriages. There are 4 important criteria on who to give progesterones. Number 1, the pregnancy has to be intrauterine and the pregnancy has to be viable. The patient has to have vaginal bleeding, symptomatic, not asymptomatic. The patient has to have a prior history of 1 or 2 miscarriages. It is important to ensure not just that the pregnancy is viable, but the pregnancy is intrauterine, and treatment should be continued up to 16 weeks because that is when the corpus luteal-placental shift is completed and the placenta fully takes over. And the treatment should be vaginal progesterones, which is micronized, 400 milligrams twice a day. That means 4 pessaries in the morning and 4 pessaries at night, not oral, not IM, but vaginal, 400 milligrams twice a day. And that is the recommendations from the NICE guidelines to prevent miscarriage among high-risk group of patients. So controversy number 3, ladies and gentlemen, in asymptomatic mothers, should we give progesterones? Is there benefit? The answer is no. Please do not prophylactically abuse progesterones in anticipation of preventing a miscarriage, especially if the patient is asymptomatic, especially if the patient never had a prior preterm pregnancy loss or a miscarriage, especially an oral dose. So there's no role of progesterones in asymptomatic patients. However, if the patient is symptomatic, the patient has got a past history, or the patient has got a recurrent history, the current evidence says yes, this group of patients will benefit from progesterones, not oral, not IM, but should be micronized vaginal progesterones. The dose is 400 milligrams twice a day, given up to 16 weeks of pregnancy. And that is the current evidence based on the NICE guidelines, which is extrapolated from the 2019 PRISM trial. So in miscarriages, ladies and gentlemen, asymptomatic patients, no benefits of routine supplementations. Symptomatic patients with a prior history of miscarriage, yes. Vaginal, 400 milligrams BD, up to 16 weeks. Now, what about progesterones in the luteal phase? The patient has got an assisted reproduction. Ladies and gentlemen, I'm going to focus this lecture purely in obstetric perspective to prevent miscarriage, to prevent preterm labor. It's not going to be a talk about corpus luteal support among patients who had assisted reproduction. But the evidence is clear. In this group of patients who had assisted reproduction, based on a Cochrane review, yes, there is benefit to prophylactically support, not to prevent miscarriage, but purely because the patient had an assisted reproduction. Let's talk about preterm prevention and move away from miscarriage. Now, this wonderful paper, which looked into all interventions to prevent spontaneous preterm labor and looked into what had the highest impact. Was it vaginal? Was it oral? Was it IM progesterones? Was it cerclage? Was it McDonald? Was it three-dot curve? Was it omega-3 fish oil? Was it bed rest? Was it pessaries? Was it antibiotics? Was it combination? The evidence was clear. Only one intervention had a significant impact in reducing preterm labor, and that was vaginal progesterones. Beyond every other intervention in high-risk women who are symptomatic. So vaginal progesterones, apart from preventing miscarriage among high-risk group of patients, also people believe has got a role in preventing preterm labor. So vaginal progesterones can be given if the patient is symptomatic and can also be given if the patient is asymptomatic but had an incidental finding of a shortened cervix. And that is the recommendations from the American College and the Society of MFM in US. So if the patient has got a short cervix and a prior history of a preterm labor, then yes, the recommendation is to do a cerclage. But the patient never had a prior history of a preterm labor. The patient has got a singleton pregnancy. Incidentally, you find that the patient has got a shortened cervix. Although people believe that the level should not be 2.5, it should be 1.5 and 1 centimeter if it's multiple pregnancy. You can discuss the role of progesterones in this group of cohorts in anticipation of preventing preterm labor, but it should be vaginal micronized progesterones. If the patient is asymptomatic, the patient has got a shortened cervix even after 24 weeks, although we normally stop the cervical measurement up to 24 weeks. Based on this New England Journal of Medicine paper, if you give progesterones, you can significantly reduce the incidence of premature labor before 34 weeks. You can actually prolong the pregnancy. So in asymptomatic patients who have got a prior history of preterm labor, you can give progesterones. Have got an incidental finding of a short cervix in a low-risk patient, you can also give vaginal progesterones. Moving to the next step, ladies and gentlemen, in asymptomatic short cervix, yes. Is there a role for progesterones? The patient presents with symptoms. The patient has got a threatened preterm labor, and now the patient has got a short cervix. Well, yes, based on the FIGO paper published in the FIGO journal, even the patient presents with a threatened labor, giving progesterones does seem to have a role in prolonging the pregnancy and preventing preterm labor. So it's symptomatic, asymptomatic, short cervix. Progesterone seems to prevent preterm labor. Now, what if the patient had a cerclage? Is there a role to supplement the cerclage with a vaginal progesterones? For many years, some people only give progesterones. Some people only need a cerclage. But is there a benefit in giving both? And based on this paper, which was recently published last year, in patients who had risk factors, who had a previous preterm labor, who now has got a cervical cerclage, if you combine that with a vaginal progesterones, the combination of a cerclage and vaginal progesterone seems to be superior than progesterone alone or cerclage alone. So once again, the evidence is clear that vaginal progesterones with or without cerclage or in combination seems to be superior. So controversy number 4, ladies and gentlemen, does progesterone prevent preterm labor among women with a short cervix? The answer is yes. These patients should be given progesterones up till 34 weeks. Now, what are the negative effects of progesterones? We've discussed about progesterones in miscarriage. We've discussed progesterone controversies. We've discussed progesterones in preterm labor, symptomatic or asymptomatic with a short cervix or with a cerclage. But what are the negative effects of progesterones? It may cause drowsiness. A lot of patients will complain of bloatedness and fluid retention. A lot of patients will complain of vaginal discharge, and one would often get worried whether this discharge is physiological or is because of an infection. But progesterone causes a lot of vaginal discharge. It can cause low mood. It can cause cervical atropine, and the patient actually may have a provoked bleed. It may cause abdominal pain and cramps. Sometimes it also causes ovarian cysts. I had a patient who had high doses of progesterone who had an enlarged 7 centimeter cyst during pregnancy, and sometimes may also cause a rise to have cervical polyps. And these are the negative effects of progesterones that should be counseled. And all patients on progesterone should have these symptoms being monitored because it is not uncommon for one to have any of these symptoms. Now, what are the other trials related to miscarriage that's been evaluated? I think the tablet trial, just published almost 5 to 6 years ago, showed that among patients who were clinically euthyroid, but who had TPO antibodies, giving them thyroxine prophylactically did not reduce miscarriage. The CERM trial showed among patients who have got recurrent miscarriages, giving them doxycycline did not reduce miscarriage. Interestingly and importantly, the ALIVE-2 trial showed among patients who screened negative for antiphospholipid syndrome, thrombophilia, giving these patients low molecular weight heparin in anticipation of preventing a miscarriage showed no benefits, including giving aspirin. So there's no role for aspirin or low molecular weight heparin. The patient's got no thrombophilia to prevent miscarriage. The MIFER-MESO trial showed if the patient had a miscarriage, the best success rate for a medical induction and termination would be a combination of mifepristone with misoprostol, which works better as compared to misoprostol alone. And interestingly, the most recent trial, the response trial, showed to prevent miscarriage, giving the patients a simulated granulocyte cell factors did not actually make any difference. And these are some other newer trials that have come into play apart from progesterones. So to summarize my talk, ladies and gentlemen, it is important that we practice an evidence-based medicine, not one driven by the industry, but it should be driven by science. What we do, what we told, what we practice should be based on evidence, not what we hear from the industry. It is now clear that progesterone has a role, but the best option should be a micronized vaginal progesterones. If you give progesterone in the first trimester, there's no benefits of prophylactic progesterones. It does not prevent preterm labor. But if the patient is symptomatic, the patient has got a pervaginal bleed, Please don't give Dufaston, don't give all progesterones, don't give IM progesterones. It should be 400 milligrams BD of vaginal progesterones, provided the pregnancy is viable, provided the pregnancy is intrauterine. Apart from preventing miscarriage, progesterone also prevents preterm labor. In shortened cervix, less than 25 millimeters, incidental finding and the patient never had a previous preterm, giving the patient vaginal progesterone may be beneficial. And in patients who are symptomatic, threatened preterm labor, short cervix, progesterone may delay the pregnancy. But if you are to use IM hydroxyprogesterone, discuss, explain, counsel, document the patient on the benefit and risk, and make that decision on why you're giving IM hydroxyprogesterones despite the controversies, and that should be made aware to the patient. With that, thank you so much for your kind attention. And I'll be more than happy to take your questions or address them in the next opportunity. Thank you so much for tuning in, and kindly look forward to the next video by the Malaysian Obstetric Medicine Society.